Hi, my name is Dale Hubbard, and today I'm going to discuss hypoxia and obesity, a new treatment strategy. The purpose of this discussion is to overlook obesity as an epidemic in the United States. By establishing trends based on previous CDC data, we can actually project the future of obesity in the United States as it stays on its current course. The next purpose is to evaluate current treatment strategies for obesity. And lastly, to discuss hypoxia as a physiological state, and then look at the research that shows the influence of hypoxia on adipose tissue. So a brief outline, I'm going to start with obesity. We're going to define it and then look at measurements for it, discuss it as an epidemiology, and then look at treatment and management strategies for it. Next, we're going to move on to hypoxia, define it, look at its physiology, and then its use as a treatment strategy for obesity, which is relatively new. And then finally, kind of highlight the gaps in the research where this could be improved upon. So first, what is obesity? And the first definition is from the Mayo Clinic. It says, obesity is a complex disorder involving an excessive amount of body fat. It increases your risk of diseases and health problems such as heart disease, diabetes, and high blood pressure. The next definition is from the World Health Organization. It says overweight and obesity are defined as abnormal or excessive fat accumulation that may impair health. Now remember, abnormal fat accumulation, that would be dyslipidemia, and then excessive would be hyperlipidemia. And it's important to know that you can still be obese while having a low amount of subcutaneous fat, because there are the different types with subcutaneous and visceral on the inside of the cavity there. So one of the big measurements for obesity is the waist to hip ratio, or anthropometric measure. And by the World Health Organization, they have set up these cutoff points. And so when they take the ratio of your waist to your hip, for men it is 0.90 centimeters greater than or equal to is obese, or metabolic complications, and then 0.85 for women is substantially increased risk of metabolic complications. And the World Health Organization highlights the major problems with being obese as cardiovascular disease, hypertension, type 2 diabetes, and various forms of cancer such as colorectal, breast, pancreatic, endometrial, etc., etc. Another measurement for obesity that's very popular is BMI, which is simply your weight in kilograms divided by your height in meters squared, and it will give you a number in the teens to hopefully below 40, and they have classified it here. The National Heart, Lung, and Blood Institute has made a few different classifications. So if you're under 18 and a half, you're underweight. 18 and a half to 25 and a half, you're normal. And then overweight would be that 25, greater than or equal to 25 to 30. And then they have three different classifications of obesity, actually. So 30 to 35 is class 1, 35 to 40 is class 2, and then morbidly obese, extremely obese, or just class 3 is 40 plus. And they just give these qualitative disease risks as increased high for type 1 obesity, very high, and extremely high for type 3 obesity. And then the CDC, they kind of just collaborate with the NHLBI here, but they say BMI is moderately correlated with more direct measures of body fat, such as skin fold assessments, bioelectrical impedance, DEXA scan, and hydrostatic weighing. So they're essentially saying that using BMI as a measure for obesity is it is a good substitute for being a cheap measurement, and to be done on a mass scale. It is easy to gather people's height and weight, and then adjust their BMI from there and compare it. Whereas these other measurements might be more accurate, but they're more costly, and it's difficult to do on a large population. And so looking at these other measures for obesity, we know that there are the DEXA scan, which is a bone density scan, and you can indirectly factor out a person's obesity from that to sense their body fat. And then there's hydrostatic weighing, where you're sensing the density of a person, and you know that fat is less dense than muscle. Skin fold assessments, we know that they're very easy to use in all settings. However, there is a 3 to 5% standard deviation for that, so they're not the most accurate. And then anthropometric, again, would be the waist to hip ratio, and the Navy also has an anthropometric measurement of their own, where they take, I believe, 5 different measurements, including the neck and the thigh. And then bioelectrical impedance, and BOD-POD, which is the air displacement plethysmography, which we consider the gold standard-ish, because the real gold standard would be cadaver analysis, which of course is impossible to do in vitro. So we mostly compare all of these other measures for obesity to the BOD-POD. Now, looking at obesity as an epidemic, just looking at current rates of obesity compared to previous rates. Now, in 2012, this study showed that 17% of youth ages 2 to 19 are obese, and then more than 1/3 of adults ages 20 or older, equal to 34.9% in the United States, are obese. And then between study periods 1960 to 1962 to 2011 to 2012, obesity in adults has increased by 22%. And then below that we have the subpoints that extreme obesity, remember that morbidly obese, 40-point BMI, has also actually increased by 6% in the same period, whereas overweight category has shown no significant change at 32%. And so we're looking at over 60% of adults in the United States are obese today. Current obesity treatment strategies include lifestyle changes. That's the biggest thing that we do as personal trainers and exercise physiologists. We look at the person's diet and their exercise. We know that calories in, calories out over a long period of time can make a huge change. I believe we know that statistic of a tablespoon of sugar a day can lead to a kilogram of body weight over a year's time. And so having somebody change their whole lifestyle to accommodate for and keep off the weight loss is critical, and it's the biggest impact that you'll have for an extended period of time. And then beyond that, there are prescription weight loss medications. This is kind of a last resort for people who have genetic or acquired disabilities for losing weight loss, and that might be hypothyroidism or diabetes, etc. But here are some examples. Orlistat is a drug that will prevent your body from absorbing, I believe, around 1/3 of the fat intake, but the side effect then is that you have diarrhea-like symptoms because it's making you essentially lactose intolerant, but to every kind of fat. So it's kind of a big trade-off. And then the last three, Belviq, Saxenda, and phentermine, those three are satiety increasers, so they just make you feel more full. And then they have various side effects of their own, such as nausea, and it's also just a trade-off. And these, again, you're not going to take these if you're just a little overweight or you're just starting off your lifestyle change. This is something that people with problems will generally be referred to by their doctors. After that, there is a surgical intervention, and then we know that the big one would be liposuction, and that would be hopefully just reserved for morbidly obese people that have tried everything else, and this isn't just kind of a cop-out, because people who go for surgical interventions will typically relapse if they're not serious about this, and this is just kind of like a saving grace. This is affecting your lifestyle, so they suck out the subcutaneous fat, whereas gastric bypass, they take where your esophagus will insert into your stomach, and they'll cut off that distal portion there, and then they'll go just beyond the pyloric sphincter to the duodenum. They'll cut that, and they'll actually attach the two, bypassing the stomach, and it's looks like a pretty gruesome procedure. And this obviously makes you feel full because you don't have space for all that food, but then you're missing all of the functions of the stomach. So that has obvious drawbacks. And then the last one that I have up there, but this isn't the last surgical procedure, is the laparoscopic adjustable gastric banding, or lap band for short. And that is just a high-tech belt that goes around your stomach, and the surgeon can adjust it to different sizes. And this just also increases satiety, makes you feel more full, so that you're getting a reduction in calories throughout the day. And then the last surgical, or not the last surgical, but the last obesity treatment strategy that I have up here is hypoxia as a question. So let's look over what hypoxia is as a physiological state in humans. Hypoxia is defined as a condition of deprived oxygen in the body region, the tissues, or the cells. And I have up there that ambient sea level oxygen is actually like 21%. And then the way that hypoxia is measured, at least in humans, either indirectly via SpO2 with pulse oximetry, or SaO2 with blood gas analysis or other measurements, and you're essentially measuring the hemoglobin oxygenation. And so how this works is that we know that hemoglobin will carry up to 4 units of oxygen. And so if by arbitrary numbers you have 1,000 units of hemoglobin carrying a maximum of 4,000 molecules of oxygen, what the pulse oximetry does is it senses how saturated that hemoglobin is with oxygen. And so if you're only carrying 3,600 units or molecules of oxygen, that's a 90% saturation. And so an extremely accurate measure would say that you have a saturation of 90%. And this study down here was a Japanese study that showed pulse oximetry is reliable above saturation values of 80%, but then below that, it has reduced accuracy compared to the blood gas analysis, which I think is fine, because when someone is at 80% oxygenation or lower, that's a critical medical emergency, and you wouldn't really want to rely on a pulse oximeter unless you're just bringing them from an ambulance to the hospital. If they're at 80%, hopefully they're getting advanced medical care and getting their hypoxia levels and their hemoglobin oxygenation measured more accurately. So continuing, the physiology of hypoxia has a lot to do with the hemoglobin dissociation curve and the affinity for oxygen and hemoglobin. And a few things influence this, such as increased partial pressure of oxygen in solution measured by millimeters of mercury of pressure. As partial pressure of oxygen increases, it also increases the hemoglobin saturation. And at sea level, the pressure of oxygen in your alveoli is 100, and you don't actually see a decrease. We'll see this on the next slide in the oxygen hemoglobin dissociation curve, but you won't actually see a huge decrease in the saturation value until the pressure of oxygen in your alveoli decreases to 70 millimeters of mercury, which would be hypoxemia here at less than 90% hemoglobin saturation. And at that point, you're going to see definite decreases in athletic ability, at least in aerobic. This does not affect anaerobic capacity. And a decrease of 30 millimeters of oxygen down to 70 in the alveoli is corresponding to atmospheric oxygen content of 14.5%, or an altitude of 3,000 meters, after which hemoglobin sharply loses affinity for oxygen. Now here's the oxyhemoglobin dissociation curve, and I just have this up here to show the main takeaways from this. Here's your 100 millimeters of mercury, and you're going to be about 98% saturated with hemoglobin at this point. This is in your alveoli, and so as you decrease to 70, you can see going across, you're now at 90, and it's going to sharply decrease at that point. This is typically good when you're measuring these partial pressures in your body, because you want, from your alveoli to your blood to the various muscle tissues, you do want to lose pressure so that hemoglobin is more easily dissociating from, or oxygen, is dissociating from hemoglobin getting to your tissues. If this doesn't happen, if this curve moves to the left, and it's more difficult for oxygen to dissociate, you will start to show signs of cyanosis and getting blue, and it's just a general not good thing for athletic performance or health. And so the main takeaways are a lower pressure of oxygen equals lower saturation. We can see that obviously here. And then over on this side, what is going to move the curve to the right, that will be a lower dissociation, and this is good, okay? So lower pH will be lower dissociation, higher 2,3-DPG, which affects the affinity for oxygen and hemoglobin, and then higher temperature will also be lower dissociation, as well as the Bohr effect as an increase of CO2 and the decrease of pH with the sodium bicarb. That will shift the curve to the right and decrease the dissociation. Now, some complications of hypoxia. As the SpO2 value decreases lower than 90%, that's considered hypoxemia. And at this point, you're going to possibly experience peripheral pulmonary and cerebral edema, so that fluid to those tissues, sleep apnea, and asthma-like symptoms. These are kind of altitude sickness or acute mountain sickness. And then just to remember, with that 90% below that hypoxemia, healthy individuals should remain above 90 until about 3,050 meters, above which the partial pressure oxygen is 14.5% and decreasing. So humans are pretty resilient to altitude until about 3 kilometers. And now let's look at the research on hypoxia, kind of seeing where scientists have experimented with hypoxic conditions and weight loss in humans. These first two look at an increased BMR at altitude. The first one, these were actually done both by Butterfield et al. This is an older study, and then they wrote in on this study, which is more current. But the first one is women at altitude, energy requirement at 4,300 meters. Both of these were performed at simulated altitudes of 4,300 meters. And this first one showed that acute hypoxia in women shows an increase in BMR. The total energy requirement increased to 6% by day 3 at altitude and remained elevated through a 3-week sojourn. Mawson et al. Found that a caloric increase of 1,250 kilojoules a day was required to maintain the subject's body weight. And we'll see later that you need about, for a 70 kilogram person, 10,000 kilojoules of energy a day. So this was over a 10% increase in that just to maintain the subject's body weight. Going down to Butterfield et al., increased energy intake minimizes weight loss in men at high altitude. So again, over 3-week sojourn here, both of these were 3 weeks too. Over a 3-week sojourn, 7 men showed an increase in BMR by 27% on day 2, but by day 10, their BMR plateaued and maintained at 17% increase above sea level. And then they measured that their caloric intake required to maintain their body composition increased from sea level value of 3,000 kilocalories a day to 3,400 kilocalories a day. So that's just different units here. This is just energy intake and then calorie intake. We can see that both studies have shown your BMR and your energy intake will have to rise to meet your rise in BMR in order to stay at the same body composition at a higher altitude. Further research on hypoxia, going into the physiological responses. This first one performed by Cochin et al., thyroid responses to stimulated altitude, found that exposing humans to low oxygen conditions led to an increase in thyroxine plasma concentration. And upon recovery, however, thyroxine plasma concentration returns to pre-altitude exposures levels rapidly. And so that would be, we know that with hypothyroidism, people generally have problems with weight and obesity, and so your thyroxine is influencing that fat metabolism. And so exposing humans to low levels of oxygen will actually show an increase in thyroxine, whereupon returning to pre-altitude levels will lower the thyroxine to base level. And then the next one, interleukin-6, regulates human adipose tissue, lipid metabolism, and leptin production in vitro. So they showed by Trujillo et al. Administration of interleukin-6 increases release of leptin in both subcutaneous and visceral fat depots. And then this is good because interleukin-6 actually increases the rate of lipolysis in the absence of insulin. So assuming that they're not getting these insulin spikes from high glucose food, administration of this interleukin-6, which interestingly is with every muscle contraction released from your muscles. And so during this research paper, these researchers were actually saying that the muscle system has endocrine-like responsibilities when it releases this myokine. And so interleukin-6 influencing fat by lipolysis in the absence of insulin. This is another important thing during altitude because your IL-6 levels will also increase during altitude. Okay, looking at further energy intake in hypoxia, Westerter Verwegen et al. Found that subjects, this whole study was a simulated ascent of Everest over 31 days at various altitudes, and they gave the subjects a questionnaire such as, how do you feel with, how do you feel satiety, hunger, do you feel like your energy is low? And throughout the study they actually had palatable foods in front of the subjects the whole time, but the subjects showed a decrease in hunger and just a general increase in satiety. They felt full at higher altitudes, and so they were taking in less energy. They lost on average 5 plus or minus 2 kilograms over 31 days. And they reached a maximum reduction in energy intake of 4.2 plus or minus 2 megajoules of energy a day. And remember, the typical energy requirement for a 70 kilogram person is 10 megajoules. So some of these people were at 4 to 6 or lower for their intake and energy, and that's a massive decrease. We're talking about a lot of body mass being lost, and then lastly, that their meals were just getting smaller and smaller and smaller, but their frequency was going up as well from 4 to 7. And more research here. So Kong et al. Was showing this is more along the vein of where I'm getting at with using simulated normobaric hypoxic conditions. Kong et al. Showed that in simulated altitude and controlling for diet, subjects could lose, minus 6.9 kilograms in hypoxia, whereas in normoxia, doing the same controls for diet and exercise, you would lose 4.3 kilograms. And this is over 4 weeks, exercising three times a week. And they also showed an improvement in systolic blood pressure in the hypoxia group of down 7.6%. So these are good. This is good data for following up on hypoxia as a treatment strategy in obesity. And the last research article that I have by Netzer et al. Did essentially the same thing as Kong, except they didn't control for diet. However, they still saw a significant decrease in body mass of down 1.14 kilograms versus a control of 0.03. And this was doing low intense physical exercise for 90 minutes, 3 times a week for 8 weeks. Normobaric hypoxia. Now the theorized mechanisms, to summarize, of why hypoxia influences fat loss are an increased resting metabolic rate and activity energy expenditure, increased sympathetic nervous system and thyroid activity, increased interleukin-6 release, increased satiety, feeling more full, and then malabsorption of the macronutrients. So you're not absorbing, I believe fat specifically was not absorbed as well in altitude simulations. And then these are just gaps in the research that I brainstormed. So ways that hypoxia could be researched in the future to see its effect on obesity would be progressive overload of hypoxic training condition, comparison of hypoxic chamber to hypoventilation training, different subject groups such as how hypoxia in exercise affects the youth or how it affects the elderly. Again, taking caution with both of these groups, and then combining specific diets with hypoxic training, such as the ketogenic, high-fat, low-carb versus the carbohydrate-loading, high-carbohydrate diet, and then high-intensity interval training in hypoxia versus long, slow duration in hypoxia. And then lastly, the evaluation of the respiratory exchange ratio while training in hypoxia to see substrate use. And with that, you might expect to have a higher respiratory exchange ratio because you're getting less oxygen than carbon dioxide. But these would all be interesting to expand this field of treatment of obesity further in the future. That's all I have for this discussion. Here are my references. Thank you for watching.